We're going to move on now to the state of the science, treatment as prevention and or treatment for treatment. Our moderator is Jane Anderson, who's the expert advisor for HIV, sexual and reproductive health for Public Health England. Thank you.
Okay, have we got an assembled panel? Is everybody here? Great. Well, after that last panel, which is incredibly provocative and have left us with all sorts of questions about treatment, we're now going to move into exactly that moment where the person who has had the test and has now had a diagnosis of HIV is going to start entering into a treatment situation, whatever that might be. And we have a great lineup of people. Ruben Branich, who's going to give us our main presentation. Rive Amico from the University of Michigan, who's well known to everybody, who's a real expert on adherence. Nikos Dedis, who is from Positive Voice in Athens, in Greece. Welcome. Sarah Fiddler, a colleague from London, a doctor, a clinician, working on cure, working on early infection, and a late addition, Peter Charutish, who is working on global health at the University of Washington. And we send our best wishes to Dr. Paula Munde, who was due to join us from Uganda, but is unwell and unable to fly. I think what we're going to talk about now is incredibly important. The first things I'd just like to put on the table are we're talking about treatment, we're talking about prevention. I want to just ask whether we know what we're talking about, whether we understand the terms we're using, whether we know what we mean by treatment and prevention, whether we know whether we're trying to stop AIDS or trying to stop HIV, and how accurate are we being in what we're talking about. And I'd like to now hand the floor over to Ruben, who's going to give us his presentation, which I hope will stimulate a really interesting discussion. Ruben, over to you.
Thanks for this opportunity to speak with you all. I was thinking about it and I thought, what haven't you had enough of? And I think it's PowerPoints. So I want to give you a few more here, if you'll bear with me. The other thing that I was thinking about is that I can't seem to take direction very well. I'm not very good at that, as my supervisor, Badar Assam, will attest. And when they gave me this title, I decided I really wanted to work with it a little bit. So I don't think it's treatment is prevention or as prevention or these sorts of things. I think it's actually treatment is prevention. Now we've come to this point. And it's not all the prevention, but it's a lot of it. And I think we just have to kind of relax with that a bit and work with that. And then when I started thinking about prevention, I thought, well, is it transmission? Is it what is it? And then I started listening to them. It's illness. It's death. It's transmission. It's prevention of costs. It's loss of social capital. It's loss of human rights. And then I would urge you to kind of fill in the blank there in terms of the different benefits. So I see treatment as very, very broad, and I would encourage us to all see it that way. Now, I wanted to also get us a little bit warmed up here, et cetera. You've probably seen this. This comes from Jeffrey Moore. It has to do with technology adoption. And there's a chasm there, right? Enthusiasts say, try it, Visionaries, get ahead of the herd. Pragmatists, oh, we need to stick with the herd. Conservatives, hold on, we don't want to do that. Skeptics, no way. So I want you to think of two things. One is, think of yourself. I mean, where are you on this scale? And you can think of things like smartphones or PCs or treatment as prevention or these sorts of things. And I was going to ask you to just raise your hand, like how many people have a smartphone or how many people think treatment as prevention is a worthwhile thing. I'm not going to do that. But as I go through the talk, I want you to kind of think a little bit, hey, where am I? Am I an enthusiast on this? Am I a visionary? And then what will it take to kind of get the pragmatists and the conservatives kind of on board? And the skeptics, I think we're just going to have to wait a long time for them and probably ignore them. Sorry, for all you skeptics out there. I didn't mean to offend you. So look, here's the, and as I introduce these concepts, you should be thinking about this a little bit as well. Like, oh, no, this is a terrible idea. Oh, this is a great idea. Let's try it. But UNAIDS, we're putting out these treatment targets, and we need to get to scale on these. That's 90% of people tested, 90% on treatment, and 90% virally suppressed. And you've heard a lot about that, and we're really excited about this. Now, for all the skeptics and the pragmatists and the conservatives out there, coming here, I was thinking about ending AIDS 90-90-90, and I thought, well, I better just look this up in the dictionary. Now, a funny thing happened. I went to the American dictionary, which is the one that everybody should use, And, and it says capable of being done or carried out. And I thought, that's fantastic. I didn't put up the British or the Oxford definition, which is a little bit different. Before you think that things aren't feasible, just think about the folks that were working on smallpox eradication. I mean, things were very difficult back then. Air travel took longer, et cetera, no PCs. Look at the guinea worm eradication and look at the people walking on the moon. And so, you know, I think I would argue that we're in much, much better shape than these folks, and they were able to be very ambitious, and their projects ended up being feasible. So bridging the chasm, how can we get these innovations? And now I'm going to get to this kind of the science part of the talk, and I'm going to talk about a few select innovations. Before I get there, I'm sorry for all of you that have innovations that I don't mention, and I probably mentioning the wrong ones in the wrong order, but these are some of the things in terms of treatment and testing that I think are important, and we need to think about how we can actually bridge this chasm with them to go to scale. We heard a lot of great ideas this morning on it. Here's the Tacoma Narrows Bridge. You've got to see that video when it just kind of wobbles and falls down. That's not us. We are the San Francisco Golden Gate Bridge where I come from. We're going to bridge this chasm. So the first innovation, and this should be basic, treatment works. There's a Lazarus effect. People get better, and it's after a very short period of time, and we have started to scale this up. The second is that we're coming to the realization, and this is the 052 data, but there's a lot of other data that actually treating earlier makes sense. You treat people earlier, they stay healthier, they're less likely to get sick. And how early is, of course, a debate, but I think it's more and more likely that it's going to be as soon as you're diagnosed, you should start thinking about going on to treatment. And that's coming to us. CD4 counts, we've been relying on them. Turns out that viral load is actually probably as important, or if not that as important, more important. And your progression depends on your viral load, and we need to start measuring that and thinking about that. So here's an innovation that we know, and it's been out there for a while, and we're slowly starting to actually scale that. What happens when we scale? We know that it has a huge impact. You see increases in life expectancy. The declines are surely due to HIV, although this is, of course, ecological. You start putting treatment there, and then things start improving. So we got curious about this at UNAIDS, and we started looking at the annual rate of death per 1,000 people living with HIV. Now, these are all estimates, and I'm hesitant to call out certain countries, but I saw that Ambassador Birx was doing it, so I got a little bit fired up and encouraged. You see Nigeria there. Actually, their treatment hasn't scaled up very well, or it needs some improvement, and they're at 65 per 1,000. You see South Africa scale up, deaths declining. And you see Botswana heading down towards the United States, which is quite remarkable, but shouldn't be surprising to all of us. So treatment does work to prevent illness. Now, look, we can bring testing. We've heard a lot of that this morning. We bring testing to everybody in very different venues. At their home, President Obama there is in his home country of Kenya getting tested. And you see down here at the bottom, yeah, go figure. You see down here at the bottom, you see all those people lined up. That's what we need to be thinking about. How do we get something like testing to these people? These were 40,000 people who were tested in Kenya in 2008, 18,000 of them being men. What was it that they did there that we're perhaps not doing in order to scale? That's the challenge for all of us. Now, what about viral suppression? Look, Rwanda, now it's a unique country, but Rwanda, 83% of viral suppression on a population basis. So it is possible. It is feasible. How do they do it? We need to learn that. We need to scale. And then transmission. I just want to put this up just to remind us a little bit. You know, this is Quinn and those folks that were working in Uganda. This is another African solution for us. It's basically, if you suppress, you don't transmit. And now we've had... I could stand up here for about 45 minutes and talk about all the studies that show that if you're suppressed, that you don't transmit. Latest one was partners. I'm kind of tired of it all, so this is the one I'm going to show. But we need to actually scale this. If you're on treatment, you actually don't transmit, or it's very unlikely. Communities, and many of you were part of these studies, communities actually, when they scale treatment and testing, they find decreases in incidence. Everybody says, oh, no, this is ecological, it's not true, or whatever. I think for these communities, they're happy that they scale treatment and testing, and they're doing a lot of other things involved, and they're good to see their incidence go down. And we need to learn from what they've done, and in cities and other communities, how can we do what they've done in order to impact the epidemic. And here we see Tanzer's work, which was, I thought, amazing because it showed that what happens in the community actually matters for the individual. Now, this is a cohort. It's an individual risk of getting HIV. And it turns out that if in your community there's a high level of ART coverage, your risk goes down, and that should make sense. But it matters as an individual what your policies are and what your implementation looks like. So we need to scale that lesson as well. Here's a paper that shows that suggests that by modeling, if you scale, you save millions of dollars, or I think it's billions of dollars, and millions of lives. Okay, probably the figures aren't quite right. If we check them again, we'd be wrong. But directionally, I'm convinced we're correct. And we need to scale that sort of thinking in terms of the investment in treatment. Okay, so that's it. That's the science. And again, it was very telegraphic. You can go back, and these are more pictograms. You can go back and read the papers. But I think that's some of the key messages out of treatment and testing that we know and that we need to think about scaling. So let's just look at tracking. How are we doing in terms of tracking our progress for this 90-90-90? And it's not too early. We've been tracking towards this already. It's not too early to start looking at that. So that was a challenge for me. I was like, what do I portray here? Do I portray a bunch of epi data? What do I portray? So I first of all, I went back to our gap report, which is great, and I thought, I had a whole slide on the optimism. We've got 14 million people on treatment, basically, about now. We're doing really well. We've tested about half the people. We're making progress. We're not landing on the moon yet, but we're on our way. But then I thought, I'm gonna focus a little bit on the snapshot on kind of what our gap is. We have half the people, and this has been said, we have half the people that don't know their HIV status. Now, this is an infectious disease, 100% mortality, and we're 30 years in. We've been spending $10 billion or $20 billion a year. We probably could be doing better in that area. We've got 22 million, let's say, or a little bit less, that are not on treatment, and that's a 76% figure for children, 1.5 million unnecessary deaths, 2.1 million new infections. So we have a long ways to go. I think my argument is that we have the tools in order to get there, but we definitely cannot, as Ambassador Burke said this morning, we cannot stop now. And we know that everyone living with HIV will eventually need treatment. So we kind of got to get that through our heads. It's if not now, it's going to be soon. And the data actually says it's going to be within a year, or they're going to be eligible within a year or 2 years. So we have to prepare to meet them as they come up the escalator with services of quality and that are efficacious. And we know that treatment is part of the solution, because as you treat more people and as you use other prevention methods, you end up decreasing incidence and reducing all your costs and these sorts of things. Now, I wanted to turn to policy, and it's good to focus on that because I use that as a surrogate, because WHO's policies are amazing. The guidelines are incredible. They review all the data, et cetera. They get all of these innovations and they put them out in these guidelines. And Meg talked a little bit earlier about the diffusion, and we do it slightly differently. We collect all of the policies that are out there, and these are the written policies. So it takes a while to get things into writing, but we believe that things are in writing are important. And we look at 94 policies. We have the world's largest database on this. We collected them over about 3 or 4 year period. It's very, very terrible work, but luckily somebody else does it. And and so 26 countries, representing about 27% of the burden, are at less than 500 or above, which is basically the WHO guidelines. So our take on it is that, let's say it's 30%, let's say it's 50%, but we're still not there in terms of our policy diffusion. So if our policy is here, or even a little bit better, then how are we going to get to the 90-90? We must go much more quickly, and we actually need answers. Is this cycle where every 2 or 3 years we develop policy, and then every 2 or 3 years countries adopt it, and they wait for financing, and is that the right cycle, and is that going to get us to get us on the green line, as Ambassador Burke says? Now, what about viral load? This is some MSF data. Viral load, I think most people agree, is pretty important intervention, and here we see the penetration, or where we're at with that, and clearly a long way to go to get this viral load technology to people who actually really need it. How long is that going to take? Is it 5 years, a 10-year process? And we're all working on that, but we should be monitoring and tracking that. Now, going to Cascade. Cascade is also important. This is an intervention. This is a concept, Cascade. Wow, blow your mind. But that we actually haven't really implemented. So we actually need to implement this. We need to measure it. And the people in TB would say, well, what? You guys just diagnose people and then you let them wander off and you don't treat them and you don't get them in care? Yeah, we're working towards implementing this. And the thing is that we're doing okay, but we could do obviously much better. And we're hoping to see cascades coming not just from research cohorts, but from countries in the near future. And then I wanted to talk very briefly, and I'm getting to the end because I want to leave time for the panelists, about what we're doing at UNAIDS in terms of liberating the data or ending data hoarding, or however you want to look at it. We've got the situation room that's going. It's going to be very exciting. It's going to allow us to actually use the existing data to look at trends and also go to subnational level. And also there's a component that allows us to do real-time stockout monitoring. If and when that gets rolled out, that's going to change, I think, our ability to monitor this 90-90-90, and we look to all of you to help us do that. And many of you are already involved in collecting and analyzing the data. We have to get the data out. We have to start mashing things up. We have to look at what's going on spending on ART, what's going on in terms of our trends, and what's going on in terms of coverage. Those are the three things. And then we have to be able to look forward into the near future. And people are working on that, but that data, I would argue, is not available enough. All of you should have access to that. We should all know how many people will be tested next year, how many people are projected to be on treatment, how much is it costing, and all these things. Not an epidemiologist like myself sitting in a dark room with an Excel sheet. Not a small group of epidemiologists, all of us. That's what I would argue. And you see AIDS Online is a great portal for that at UNAIDS, and you see PEPFAR moving in that direction as well. And Global Fund has something. Now I want to talk about cities. This is not just global, pie in the sky up about 50,000 feet. We have to get into detail, and this is San Francisco's looking at viral load, and we need to start looking at this sort of thing focused and mashing it up with other things in terms of testing and treatment to see where our interventions should go. A lot of people had already talked about that. Last slide here. This is kind of the take-home messages for me. I think we need to think big. The guys and gals that were going to the moon, they didn't think about just person flight. They thought about going to the moon and walking on the moon and getting back. So we have to think big, set big targets. We have the tools. Testing and treatment are definitely going to be part of the scale and are going to be part of the solution. We have to work with the community. You saw the picture. It has to be like that. It's not going to happen unless people actually want it and we provide something that they really want. Cell phones are a great example. We need to be on that. Coca-Cola, I hate to use that corporate reference, but everybody wants a Coke. How do they do that? What are they doing? We have to start thinking like that. We need global solidarity to finance a scale-up. It's not going to happen at an individual basis. We should think about our financing. Is our yearly budget's the way to go? Shouldn't we have more regular financing? We have to start thinking about ways to move more quickly there. We have to share our data more. We need wisdom of crowds. I mean, cities in California are doing, and other places in the United States and elsewhere, are doing hackathons. They get kids in to work with these computers and figure out applications that actually solve government problems. We are still in the old days where we have the data and we don't let people have it, and we're not engaging enough with the people that need the services. And then we should mind that innovation chasm. We need to understand kind of what is it about ourselves, what is it about our products, and I hate to use that word, but what is it about our innovations that we need to change and shape so that we can bridge that chasm and so that the uptake is far more rapid. It's not a 10-year cycle, it's not a 5-year cycle, it has to be far more rapid, and we need to work on that, all of us collectively. So thank you. Obviously these views aren't the views expressed in this presentation are not UNAIDS, et cetera. You saw the way. So thanks.
Wow. Okay, Ruben, thank you very, very much. You've really set us a lot of questions. You've given us a great deal to discuss. And I think what I'd like to do is to ask each panelist to just give us their immediate first response to what you've said. And I'd actually like to start with Nikos, because the big issue, this has to be what people want and what the community wants. So can we start with you giving us a sense of where Ruben's talk has resonated with you?
Yeah. Well, thank you for the invitation as well. I think that, as we know very well in this room, is, for me, the problem of these last few years with regards to this issue is that the scientific community, the policy community, and the people living with HIV community has been split. We have not managed to speak with one language on this. Only recently, I know occasions where in Greece, people who went to ask for PEP, and then they knew who the index case was, which was an individual who was living with HIV, on treatment and undetectable. The doctors still gave post-exposure prophylaxis. So doctors do not believe that putting people on treatment is sufficient to stop, or at least it just doesn't register sufficiently. So I think that here we have a communication and a comprehension gap, which, if it exists among scientists, obviously we can know what we can expect from policymakers and indeed what we can expect from the community. So for me this has been a communication failure over the past few years from all these people that we are in this room. And of course imagine that if we cannot convince ourselves, what happens when we go one step further away, trying to convince other people who need to sift finances between responses, given what is the burden of morbidity and mortality. So, and I think that and a few comments from what Ruben presented, he didn't present anything new on science, and this is supposed to be the state of the science. So we still have the same instruments. The only thing that we typically see in these meetings is WAFA's latest update on the clinical trials that we expect might show something on an ecological level. Perhaps this could help convince. But for me, the issue is that we need to really somehow, I'm counting on this meeting that comes up on the 25th of September in New York. I think that UNAIDS has to pull this through, together with all the critical players, WHO included. So for me, it's a communication failure that I see here.
Thank you very much. And I think I would next perhaps turn to Dr. Sarah Fiddler, because I think your point about the body language of the professionals in terms of what they do and don't believe, in terms of how they behave in their prescribing practice. And Sarah's been very involved with the guidelines and the position paper for treatment as prevention and work in that area in Britain. Not that I'm going to ask you necessarily to comment down that route, but you do have that background and that expertise. So, Sarah, where would you take the discussion from what you've heard so far?
Well, thanks, Jane, and thank you for inviting me to have the chance to actually speak here. I put down a couple of notes, having the advantage of seeing Ruben's slides before just now, and I think one of the first things that you started with, which is a really important definitions issue, which I think talks a little bit to your point, Nikos, is that we talked about treatment as prevention, and then we talk about treatment as treatment. And actually, I feel, as a clinician, this gets all really muddled up, because if you're talking to somebody who, and I do this on a regular basis because my sort of clinical work is for people who are newly diagnosed, who often have good CD4 counts. And the discussion is, do you need to go on treatment for yourself, and here's all the evidence and here's all the guidelines, and then do you need treatment for prevention? Now, if we are doing, which I hope most people in this room feel is the right thing, is to move policy towards putting people on treatment irrespective of CD4 count for many scientific as well as pragmatic reasons, then to start making a definition of treatment as treatment and treatment as prevention is really muddling, my feeling is, for the community, because they're going, well, am I going on treatment because I need it, or am I going on treatment because I'm preventing transmission? Yes. And actually what we need to do is go, if you live with HIV, we now have drugs that we feel comfortable enough, are safe enough to keep you well, and they give you two benefits. They keep you well and they stop you transmitting. So I feel quite strongly that we should stop calling it treatment as prevention, particularly as guidelines move forwards, because it becomes a sort of arbitrary and potentially confusing message. So that was one of the things. I don't know if I've answered your question, Jane. The other thing, again, that we've heard in the previous session, but also here, is this whole issue of testing. So if we are in London, so you have to grace us with allowing to hear some of our data from the UK. But if you look at the cascade pictures, if you go the other way end, so how many people have we got in the UK who know their status, who are linked into care, who are on treatment, who are suppressed? And actually, I feel very proud of our NHS because we do really, really well on that. We get our 90%, generally speaking. What we don't get is the beginning bit of the cascade, which is the testing. We still have not changed how many people know their HIV status in the UK since the whole beginning of this epidemic, although we've got outreach, we've got community testing, we've got point-of-care testing. So that's, again, where this communication with the people living with HIV and those vulnerable and at-risk communities need to be better entrenched. And I think the whole programme that Ruben did mention here is all about linking the testing. We know about the treatment, we know what message we want to give our communities. And then just finally is to talk about the grades of evidence. So the evidence that's been presented, and Wafa presented the trials, and you mentioned already, is we have ecological evidence. We think that the more coverage we get, and it all makes logical sense, I don't think you need to be very clever scientists to work this out, the more people that aren't within our population capable of transmitting because they're being successfully treated, the less transmissions there is. It's not difficult. But what about how do we do it? And we've all talked about that as well. And what really are the sort of risks and benefits? And I think that's where, again, I'd just like to focus on the justification for some of these trials, where we're trying to go, look, we all believe in treatment. We all believe in getting people linked into care. And we want to do it working with our communities. We don't want to be sitting there bossing people and telling them what they have to do. We want to hear their voices and hear what their feelings are. But how do we actually keep people in care, and how do we measure this? And this is where I think the innovation bit and getting to the moon is the really important bit. And that's where some of these trials are trying to look at how to do that in generalized epidemics. There are also many other trials looking at focused epidemics in men who have sex with men and injection drug users. And I think the evidence has got to be targeted to this, to the situation we're all in, and it has to be a combination approach. We can't expect just antiretroviral therapy on its own to actually just do the ticket. We've got to do everything, and keeping the negatives is as important. I'm sorry if I went on too long.
No, thank you very much, Sarah. That's extremely helpful. And actually, one of the things that I think, if we have time, I'd quite like to pull out is we're using treatment and the whole term of treatment as prevention, assuming that our successful measure of treatment is an undetectable viral load. And we're not thinking about the wider well-being aspects that perhaps are coming with antiretroviral therapy, perhaps the mental health benefits of people feeling calmer about entering relationships and all those other things, which probably impact on adherence. I don't know, but Rive probably does know. And again, I think maybe are we thinking too narrow? I just put that out there. And where do we go with the bigger picture of asking people to take tablets for a very long time? And that's your field of expertise. And what are your feelings about what you've heard so far?
So I think the difficult part of kind of coming a bit last is that most people have already said what you thought was compelling. So I agree with what's been said. I think that one of the pieces I did want to pull out is thinking about things in terms of the operationalization of treatment or prevention, which is typically durable viral suppression. And that durable viral suppression will afford protection or, not passing HIV forward. But there are a lot of steps between there, and I think Ruben's talk really highlighted that we're quite a bit away from even the entry step of making sure that people have access. I think I'd like to call attention to the quantity issue, right? We need more access to treatment, but I think we want to also prioritize equally the quality issue, because we heard a lot of talks today that really have said that we really need to get some quality systems of care. And if we go out and try to really increase our coverage in a way that doesn't address some problematic ways in which we deliver care, ultimately it's not going to reach either the individual health or the public health benefits that might be obtained with durable viral suppression. And the reason that I say that is that one of the things we see is and adherence is important, but I want to call attention to the reason that oftentimes people fall off of ART is because they've fallen out of care, or they're cyclically using care, or they've forgotten an appointment and they're now so scared to go back in that they're going to keep putting it off because they don't want to be punished when they return to care. So these issues of retention in care, being able to come back into care, they are critical when we start talking about quality care and what kind of patient-centered care we might be able to deliver. And just to note, when we say quality care, it's not just the performance metrics. It's not, how many people did you link? How many people are on ART in your clinic? It involves talking to patients, talking to communities. Kenley mentioned eventually with a policy, you're going to have to come back and ask me, and that's exactly right. We need to be, at this point, really checking in with our communities in terms of what is working well, what's not working well, and be able to innovate around that. Can I add one thing?
Of course.
Okay, so this is not directly related to your talk, but in some ways it is, because we thought about, or we heard a lot today about the right thing. And as a psychologist, I've kind of throughout my training, developed with the axiom of, what works best for who, when. And so there's always this assumption that there will forever be variability and there will never be one right thing. So when we start thinking about the strategies, the how-to, how do we reduce stigma? How do we increase testing? How do we link people into care and retain them? We need to have the flexibility to recognize that that needs to be performed on a local level. And yes, the large-scale trials, the randomized control trials with comprehensive or behavioral interventions are important, but they're slow. And they may or may not fit your population. So I would really love to see something where we encourage local communities, local clinics to think about what is right here. That involves talking to the patient populations, finding out where the gaps are, where are the challenges, and using their own resources to try to address it, monitor it, and come out with evidence-guided strategies that don't really have to wait or have to have one single right way.
Thank you very much, and that's particularly pertinent here in England at the moment as the Health and Social Care Act is encouraging localism, and it's having a mixed benefit on our HIV services. However, it is currently very pertinent to be talking about localism in England. One of the other things which we've been hearing, of course, is the global health perspective and where we can learn from each other. And Peter, you're a global health expert, and certainly I think we've had some really interesting examples that actually there are places we should be learning from, and perhaps the lessons aren't disseminating south to north.
Thank you very much. I think we are all global health experts here in this room. I would still like to go back to, I think, the issue that Nick was raised about the division we have as a global community when we are facing with these issues. And I think this was very well exemplified by Ruben's slide that shows that from a policy perspective, we have a big diversity of policies that range from universal access in the US to, I think, Russia that is still stuck at 200. So to me, I think when I look at this, that should really have been the point that we should have been emphasizing, and I wish, Ruben, you had just frozen on that slide alone so that we could focus on it, because that, to me, would eventually be the price that we have to pay for the inaction that I know we are talking about. I want to believe that a few years down the line, every country should actually be moving towards immediate treatment upon diagnosis. And it would be sad that we will be looking back and say, we wished we would have done this sooner. But I think as we are trying to sort out all those issues, I think one area that we should have a consensus, whether you're a treatment advocate or a prevention advocate, is that there is scope for scaling up point-of-care viral load testing, and I think this is something that should unite us, and we should advocate for that, and that should be probably at least the rallying point as we try and sort out the other bigger issues. And then secondly, I know Ruben also talked about tracking progress of the 90-90-90. I haven't seen it much, I haven't heard much in this meeting about the role of technology, the role of using unique personal identifiers to actually be able to track people through the cascade. At the moment, with technology coming up with smartphones, with the use of biometrics, whether it's fingerprint or iris scanning, I think we have some latitude of ensuring that at the point of diagnosis and through the care cascade, we are able to have actually accurate denominators that we can be able to measure this. We should be able to link laboratory information systems that track viral load to service data. I think the issue of self-testing that we mentioned also can actually benefit from technology that can be able to track people even who test themselves outside the healthcare system. So would like to see sort of this done more and more. We would, I think, be in a better position to actually be able to document impact. But I think meanwhile there's a lot that's happening when we talk about the North-South collaboration. I think the South also has a lot to demonstrate in terms of surveillance. I think Ruben just showed a few slides, Rwanda and other countries that are demonstrating already in their population surveys, so in their form of surveillance, that we're moving towards viral suppression. In Kenya, we've just finished a big national survey, and we were able to demonstrate that amongst people on ART, this is a population-based survey, 75% of them were actually virally suppressed. And overall, amongst all HIV-infected people, about 40% were virally suppressed. But I think the challenge that we need to sort of take from here as well is that I don't think we've really standardized measures of viral load measurements. I know we have other surveillance, sort of using 400 as cutoff, others at 50, probably WHO at 1,000. I think we need to standardize metrics for viral load so that we can do a better job at surveillance of viral suppression.
Thank you, Peter. And as well as standardizing viral load measurements, about standardizing well-being measures and some of the other things, perhaps there's other metrics. Ruben, I know you wanted to come back, so...
A few comments here. Is this on?
Yeah.
It's working? Great. Hey, so and I'll just a few of the comments here. Sorry about the new science. There's a lot of slides that I actually dumped that had, because I didn't actually want to get into that frame of of looking at when to start and all these sorts of things, and because I think we've moved beyond that on some level, and then that's for other bodies to actually do. But the science that I did include are innovations that came to mind that we actually need to bring to scale. In terms of the definition of task, I agree. It's been horrible. I mean, I don't know when the term came to. It was about 5 years ago, I think, that we coined it, or everybody coined it, and we've been struggling with it ever since. I would just go back to Peter's comment about about where we are in terms of policy. If you look at that slide there on where we are policy-wise, there are only a few countries that are actually moving towards the immediate treatment. I mean, there's 10 of them or so, or 7 of them. Most of them are in the north: the United States, Spain, France, Korea, Australia, these sorts of places, and Brazil, and parts of Canada, thanks to Julio. But the point being is that we're actually, I don't think we're there yet where actually people understand that treatment is actually good for both preventing transmission and for keeping people healthy and for preventing costs, and it shouldn't be both, and all of these other things. And so we're still struggling around defining that, and we need to do that. I agree on the risk and the benefits issue. I do have a slide in there that looks at risks and benefits, and I actually think that we should be asking patients what is an acceptable risk of waiting until going on to treatment. And if you ask them, I think we would be really, really surprised. You could just ask yourself. I mean, if you, let's say, had a 3% risk of having AIDS or death for waiting to 350, would that be okay? And if you had a 1 or 2% risk of adverse effects from taking the drug, it starts to get pretty complicated. What if it was a 10% risk? Wow, I think most people would say 10% risk of death, I'm not into it, and I want to go onto the drug. And it's a nonlinear curve, and that's where the behavioral economics come in. People make irrational decisions. You think it would be linear, like if you get to 5, no, you get to 6, yes. Actually, the difference between 1% and 5% is quite different for people. So I didn't want to get too complex there, but most of us don't understand, most of us can't articulate the risk of waiting from infection to less than 350, even though there were experts in this area, and that's actually a bit of a problem.
Can I stop you at that point?
I think that's good, yeah.
Yeah, because I think we've got time for one question, and being that we're sitting in a country where we are at the moment taking our treatment as prevention policy questions up to see if we can get established funding for treatment above 350, we are in an interesting state in England. So we have time for one question, so long as you're prepared to sacrifice a minute of drinking tea. One urgent question. Hang on. I think your hand was first. I'm sorry, I can't see over the lights, but...
How do we know it's urgent?
It must be urgent. I can tell you that her hand went up quickly.
Hi, Jenny Schubert from Housing Works in New York City. The role of social determinants has been raised a number of times today, but I do feel that it hasn't received yet in the meeting the attention that's required. And certainly what we know from the global north is that as the epidemic becomes increasingly concentrated among the extremely poor, that it's impossible to adhere to access or adhere to treatment without secure housing, if you are food insecure, if you have no means to care for your children while you receive treatment, or if you are if you're subjected to stigma even in the healthcare setting due to your sexual orientation, your gender identity, substance use, etc. So I just wondered if any of you wanted to comment on that at this point. I know as well
Okay,
that
can I say that we better stop with, let's just take your point. You want a quick comment from each of the panelists. Social determinants, wider determinants, what do we do? One sentence. Vivek.
Social ecological models are basically driving right now most of the interventions that are being evaluated in the field to promote linkage and retention and care, and you're absolutely right. It won't be the ticket for everybody, but it has to be the ticket for some people.
Okay, Sarah.
I'd just like to respond to that, and also in the context of policy and guidelines, and Julio's talk in a moment, but about these policies are very, very important for us to negotiate with our funders, and in the UK it's the NHS. But it depends on the delivery of the healthcare system as well. So because it has a recommendation of a CD4 threshold does not necessarily mean if you have a free to all access to healthcare that these sort of problems will not be also integrated if we're doing it properly. If you can have whatever policy you want, but if it's dependent on funding, like in the US, if I'm allowed to say, then even if you want, you can have whatever policy document you want, but if people aren't getting access to free healthcare, then all these things play out and prevent intervention.
Brilliant use of English, one very long sentence. Thank you, Sarah. Absolutely agree. Ruben, one sentence.
You're absolutely right, and if we don't take those into account with other things, the social determinants, then we won't be able to get to scale successfully. So it's clear.
Yeah.
Well, Jane, I think that you should reverse the question of how do we spend or where do we find the money to raise it to above 350. Why do we waste all that money and not move faster to save for society? And so these societal reasons why we should do the opposite.
Okay, thank you. And Peter, last word.
So granularity of the epidemic, understanding the epidemic at the very local level using technology and other techniques geospatial that would map out those social determinants, I think is crucial.
Thank you. We could have gone on for much, much longer. We've not got the luxury of time. Panelists, thank you very much. Ruben, thank you for a stimulating session. Tea is outside. And back at what time, Ken? 4:20. We'll be back here prompt. Thank you all very much.